Good evening, everyone. Today I'll be presenting a case based on the diagnosis of fundus fluorescent angiography. So, 68-year-old male came with the complaints of diminution of vision in both the eyes past 6 months. This was his first visit in January 2021. He was a known case of diabetes mellitus since 5 years. The best corrected visual acuity was 6.6 in both the eyes and 6. The intraocular pressure in the right eye was 9 millimeter of mercury and the left eye was 14 millimeter of the mercury. Other than the difference in the intraocular pressure, rest were the findings within normal limit. The patient was prescribed the glasses and asked to come after 6 months. So after 6 months, the patient came with a sudden decrease in the vision in the right eye past 1 month. Now, the recorded visual acuity in the right eye was 2 by 60 and the near vision was 660. The left eye still remains 6.6 and 6. The anterior segment findings showed in the right eye the neovascularization of the iris and the 360 degrees neovascularization of the angle, and the left eye at a primary angle closure for which the patient underwent laser peripheral iridectomy. The intraocular pressure was 18 millimeter of mercury in both eyes. This is the fundus picture of right and the left eye. Can anyone describe this fundus photo for me?
This is the color fundus photo of the right and the left eye. The right eye, the media is clear. The disc is healthy. The retina, the posterior pole is attached. The disc looks slightly hyperemic.
Okay, I'll mark the pointers.
Please compare the two eyes, then speak.
Can you tell what is there now? What I'm pointing at?
She specifically put both the eyes photographs together so that it makes it easy for you to compare and look at everything. Look at the disc, the vessels, the retina.
Anyone else can try?
Oh, Parth is there.
Arterial attenuation also in the right eye as compared to the left.
Make me proud.
Okay, the second arrow.
Dilated veins,
Yes.
disc appears as compared to left eye, disc appears hyperemic.
Okay.
Arteries appear narrow.
There is a generalized narrowing of the arteries. There is a dilatation of the veins, but there is no tortuosity. And if you compare to the right and the left eye, the AV ratio is deranged. And there are the cottonwool spots suggesting the ischemia. So this is the infrared fundus image delineating the artery and the venous very nicely. So this is a short video of the right eye wide field fundus fluorescent angiography. After the video, I'll be discussing about each phases separately. So can anyone tell the normal arm to retina time? Okay, what is abnormal? When do we call it abnormal?
More than 20 seconds.
Yeah, more than 25 to 30 seconds. And normal AV transit time? Arteriovenous transit time? Normal arm to retina time is 10 to 15 and more than 30 is considered to be the abnormal. And the AV transit time is the initial appearance of the dye in the retinal arteriole to the complete venous filling. Normal is 8 to 12 seconds and more than 50 seconds is considered abnormal. So the dye first appeared in the arteries at 38 seconds. And the second one is an early arterial phase. And can anyone describe what I'm pointing at? That was a clue from the video which I showed. Yeah, it's a leading edge. So at 52 seconds till it is in the arterial phase. And the right eye picture, can anybody describe what phase is it? Looking at the veins.
Say arteriovenous phase.
Early AV phase. So what is shown in the picture? Can anyone describe?
Lavan, you can describe if you know it. Go ahead. Then we'll skip.
It shows a diffuse leakage around the capillary, suggestive of capillary ferning. And the disc is bright. Disc is leaking.
So if you see carefully from the early pictures also, there is an hyperfluorescence at the disc. And here what we are seeing is a vessel wall staining and an hyperfluorescence of the disc due to the leakage of the disc capillaries. And the staining is mainly due to the endothelial cell damage. So what is depicted in these pictures?
Non-perfusion areas.
Yeah, peripheral capillary non-perfusion areas. So this is an FFA of the left eye. Can anyone describe? Actually, initial pictures are not there to look for the AV transit time. The thing is the fundus picture is grossly normal except for the superior temporal and an inferior CNP areas. So it is a classical fundus picture of the ocular ischemic syndrome.
Go back to that previous slide. They haven't told the abnormality in the left.
Yeah.
You told, huh?
Okay. So the classical features of an ocular ischemic syndrome, which is seen in fundus fluorescent angiography, are delayed arm to retina circulation time, patchy or delayed choroidal filling, which can be demonstrated in 60% of the cases, prolonged choroidal filling time, although not sensitive, but it is a more specific for an ocular ischemic syndrome. The eye sensitivity angiographic sign is a prolonged retinal AV time, which is present in 95% of the eyes. A well-demarcated leading edge of the fluorescent dye is typical of angiographic secondary to the hypoperfusion. The staining of the retinal vessels, both of the major vessels and their branches, is a most other common angiographic sign seen in 85% of the affected eyes. Due to the endothelial cell damage with the rupture of the inner blood retinal barrier due to the chronic ischemia, we see the staining of the retinal vessels. And in about 15% of the eyes with an OAS shows a macular edema at the late phase of the fluorescent angiography, which do not have a sussed-out pattern and is often associated with an hyperfluorescence of the optic disc, which is attributed to the leakage of the blood vessels. The retinal CNP areas is also seen and is located in the mid-periphery of the retina. Blood supply to the eye. Can anyone tell these numbers? What is the artery which are marked as 1?
This is the ophthalmic artery.
Okay. Second?
The second one is the central retinal artery.
Next.
And the third is the long posterior
Yes,
ciliary
correct.
arteries. And there is fourth. Yes, the fourth will make the circle of Zen. And
There's nothing like long ciliary zone. It's lateral
Long-
medial ciliary arteries, posterior ciliary arteries.
post.
Yeah, long ciliary artery comes somewhere else.
Okay. Most of them were correct. So the ophthalmic artery is the first branch of the carotid artery, and in ocular ischemic syndrome, we will see a global ischemia involving the both anterior and the posterior blood vessels. So ocular ischemic syndrome is caused by the ocular hypoperfusion due to the stenosis or occlusion of the common or the internal carotid arteries, atherosclerosis being the major cause. The other terminologies which were used earlier were venous stasis retinopathy, ischemic ocular inflammation, ischemic coagulopathy, and an ophthalmopathy. All these were attributed to the advanced carotid artery stenosis. The most common age group being affected are 50 to 86, and it is rarely seen before 50 years of an age. Men being affected twice as common as women, reflecting the higher incidence of the atherosclerotic diseases. Bilaterality is seen only in 22% of the cases, and in up to 29% of the patients with a symptomatic carotid occlusion manifest the retinal vascular changes that are usually asymptomatic, and 1.5% of them per year progresses to symptomatic ocular ischemic syndrome. On the other hand, ocular ischemic syndrome is the first observed manifestation of the internal carotid artery stenosis in as many as 69% of the patients. Coming to the pathogenesis, the main is the chronic hypoperfusion of the entire arterial supply, and ophthalmic artery obstruction is seen in less than 5% of the cases. Without the well-developed collateral circulation, stenosis of the carotid artery by even 50% lead to the development of the ocular ischemic syndrome. The patient presents with the amaurosis fricax, where the transient visual loss, ischemic pain due to the raised IOP, ocular angina. These are the anterior segment findings which we'll be seeing: uveitis, anterior and posterior synechiae, asymmetric cataract, atrophy, sluggish reaction, conjunctival and episcleral injection, corneal edema. And the posterior segments such as narrowed retinal arteries, spontaneous retinal artery pulsations, retinal hemorrhages which are most commonly seen in periphery, retinal telangiectasias, cholesterol emboli, neovascular glaucoma, neovascularization of the disc and the retina, which is hemorrhages, ischemic optic neuropathies, and cortical spots. The diagnosis is mainly based on the imaging of the carotid arteries, non-invasive images such as Doppler ultrasound, minimally invasive such as CT angiography and MR angiography, invasive techniques such as carotid arteriography only when you are planning for a carotid endarterectomy. So differential diagnosis of the OAS is mainly CR, central retinal vein occlusion, and the diabetic retinopathy. In case of an OAS, retinal veins are dilated but not tortuous. In case of an occlusion, we will see both dilated and the tortuous vessels. In case of diabetic retinopathy, it will be dilated and beaded. The hemorrhages are mostly seen in the mid-periphery in case of an OAS, where in vein occlusion, it is in flame-shaped and present in all the quadrants. In diabetic retinopathy, it is dot and blot hemorrhages. Based on the fluorescent angiography, the arteriovenous time is prolonged in case of OAS and vein occlusion, whereas in diabetic retinopathy, it is usually normal. The retinal vessel staining mainly occurs for the arteries and also veins in some cases, whereas in vein occlusion, veins more common than the arteries. In diabetic retinopathy, there will be no staining. Macular edema is rare in vein occlusion and in diabetic retinopathy, which is common. Choroidal filling, delayed and a patchy choroidal filling will be seen, whereas in vein occlusion it is normal, and in diabetic also it is usually normal. So diabetic retinopathy sometimes may coexist with the ocular ischemic syndrome, and with a marked asymmetry of the retinopathy should be examined for the carotid artery stenosis, since approximately 20% of the such patients have an hemodynamically significant carotid artery stenosis. Absence of the retinal artery stasis and choroidal filling defect detected by the fluorescent angiography in diabetic retinopathy and vein occlusion is important distinguishing feature between these two conditions. So we had to have a multidisciplinary approach. In the treatment from our side usually will be in the laser and the surgical, control of the anterior segment inflammation, ablation of the ischemic retina, and the control of the increased intraocular pressure. Systemic carotid endarterectomy and the carotid artery stenting by the cardiologist. So the take-home message is signs of severe carotid artery stenosis may be first observed in the eye before they are manifested in the cerebrovascular system. Early and the proper diagnosis and referral for further investigations is crucial. Thank you.
Can you show the angiography?
Yes.
Actually, they don't present with glaucoma so often. Because there's cerebral body ischemia, the aqueous perfusion is less. They do have NVI, but you won't see very high pressures. You will have pressures. It will be appropriate to just the balance between the aqueous, less production of aqueous, as well as the reduction in the antechamber angle egress. So go back, go forward. Yeah. So Lavanya said it's capillary non-perfusion. How do you say it's capillary non-perfusion? Can you actually see capillaries in angiography? We're talking about fluorescent angiography, dye angiography. Do you see individual capillaries, unlike OCTA? Do you see?
So in FA, superficial capillary plexus is visible, but in OCTA, both superficial and
You agree with her?
deep is
Superficial
visible.
capillary plexus is visible in FFA. You guys agree with her? No, don't nod your head left, right. You tell whether it is visible. You just imagine you're seeing an OCTA superficial capillary plexus and imagine seeing the FFA. How do they compare? Do you see capillary plexus of the retina?
No.
Then what do you see? If you don't see the capillary plexus, then what do you see in FFA? Then what do you see? This is plain simple FFA. Come on. No, you see arterioles. Very good. Excellent. You see arterioles, you see venules. Anything? But do you see capillaries? If you don't see capillaries, then what do you see there? How do you know the capillaries are there? Because you say capillary non-perfusion.
Perfusion.
So perfusion. How do you see perfusion? You show that. Go forward. Maybe you have some other eyes also there. But you've seen so many diabetic FFAs. What happened? When do you actually start seeing capillaries or effect of capillaries? Diabetes is the biggest example. When do you start seeing it? She said telangiectasia, dilatation of capillaries. That's when you actually start seeing capillaries. Since they're dilated big enough, and now they started leaking, then you see capillaries. Otherwise, you will only see a general stain. Look at that. You just see a general stain of the. But when you see non-perfusion, you'll see it like that. But what is happening in this case? Here, she's saying it's an arterial disease. The arteries are getting stained, and that's not capillary furning that you've seen, okay? The arteries are staining because they've become damaged. So arteries, arterioles, all the arterioles, whole arterial system is getting stained. There is an extreme kind of disease, Takayasu's arthritis, which also is part of the ocular ischemia. It's not a disease of the retinal vessels, but it still has an effect. You will see microorganisms all throughout the fundus, an extreme form of poor perfusion of the eye. You don't get a classical OIS. That is, you don't see the capillaries, but you see the effect of the capillaries. When the capillaries are disappeared, then you see a non-perfusion. You see boxes of non-perfusion between adjacent vessels, arteries and veins. So you see the non-perfusion. But the perfusion is a general flush that you see. You start seeing capillaries, or the effect of damage in capillaries is when you see microaneurysms, when you see telangiectasias, when you might see irmas, you might see collaterals. Those are smaller level vessels, not arteries. So that is the reason why you can't call this non-perfusion of capillary non-perfusion. Generalized loss in population is there in this eye. The whole routine retinal flush is gone. It's a dark looking FFA if you compare with the other eye. Look at the color fundus. What she wanted to show you was, see the difference in the color of the two. You can go back. That's the video.
Going.
Look at the color of the veins. This is blood which is sitting in the vein, not moving forward. Really deoxygenated blood there. See the dark colored vein. Look at the vein on the right hand side. So there's definitely a sluggish circulation in the eye, and that's why the veins are dilated. And actually, you won't get bleeding, but you get, you see the upper vein, how it is, like a fusiform dilatation. That is a clear indication that the flow is less. It's not CRVO because the veins are not beaded enough, right? And they're not tortuous enough. And you don't have any hemorrhages here. The disc is absolutely flat. It's not edematous. So you have to pay attention to these things. FFA is just not like that. You just see and write. Looks like active CNVM. Looks like CRVO. Straight diagnosis. Like, you must pay attention to all the features. Anything you want to add?
One last question. If a case of a CRVO of a old nature comes and you have kept in mind of OIS, do an angiogram, how do you differentiate between the two?
So the choroidal flush will be there, starting, and then comparing the delayed AV time, arteriovenous transit time, and
in both cases there will be a delay, right?
Yes, sir. But the patchy and choroidal filling is characteristic of an OAS, and the veins will be dilated and tortuous, and we will see a multiple, if present, then NVEs if it is in very old.
You get a disproportionate. We may not have many changes in the fundus, but anterior segment ischemia with some obvious. You may see rubeosis, angle neovascularization. You do not see, in fact, new vessels on the retina. That again gives you something that you are dealing with ischemia.
And one more simple fact. Very unlikely, if there is no inflammation in the eye, the fovea is flat. There's no cystic spaces.
Yes.
Because there is no vessel there, which is going to cause leakage. You see in your own FFA, there's no foveal leakage around the fovea.
Yes.
Right? It's ischemic, something like CRAO, but a chronic, slow perfusion.
Global hypoperfusion.
Yeah, so you won't get a cystic fovea. Very rarely you might see if there is some inflammation, associated inflammation which is happening because of the anterior uveitis, because of the OIS.
Yes.
We don't do orbital ultrasound here, but once upon a time we used to send to Mediscan to get orbital ultrasound to look for the ophthalmic artery.
Yes. Ophthalmodynamometry.
Yes. Yeah, that you can do to see the
perfusion pressure of the artery.
Okay.
Very much there.
Amen. Any questions?
Yeah. Not a question, just a comment that sometimes you see nothing except mid-peripheral blotchy hemorrhages in the retina, and everything otherwise looking normal on a routine consultation. In those cases also you need to look for ocular ischemia. It may not always present with dilated veins, but yes, dilated veins, vision normal, and lower intraocular pressure on that side is fairly typical of an ocular ischemic syndrome. The pressure will go up once the block is correct.
Yes, ma'am.
So that's an important point. Once the patient is sent to a
cardiologist.
Not cardiologist won't take care. It's neurosurgeons who take care of this, I think. If they relieve the block or they do the carotid endarterectomy, the perfusion may increase suddenly, and you'll have a lot of problems in the eye. You could have new blood vessels suddenly popping up, a lot of hemorrhages.
Yeah, and Probably this case was picked up because you had early pictures in both eyes. Unless you're really looking for something very specific in one eye that requires you to have 100 images of the same eye, whenever you are suspecting this kind of asymmetric pathology, it's always important to ask for early films in both eyes, speak to the photographer and tell them that this is what you're looking for. So to make sure that timer is working right so that you have a clear idea whether really the filling is delayed. Or sometimes you have very thin people, it takes a long time for the dye to reach the retinal circulation. The photographer lifts the arm up just to make sure the dye goes in fast. These kind of maneuvers should not be done when you're suspecting ocular skin.
So if there are no more comments, if there are any questions, you can question.